So my talk is titled Health Information Technology Errors. And some of you might be wondering, in a talk where there's so many enthusiastic people about, transforming healthcare through the use of IT, why would somebody come and talk about health IT errors? But what I want to try to convince you in the next, hopefully just maybe 7 to 8 minutes, is that you really have to think about this as a complex problem. The design, development, implementation, use, evaluation of health IT is really complex and is prone to failure. And we really will get it wrong unless we plan this correctly. So my colleague Dean Sittig and I sort of started thinking about hazards related to technology several years ago. And the Institute of Medicine, who actually put up a health IT patient safety report recently, convened a panel to think about what are health IT errors. And we started thinking that health IT errors are those that are related to failures of technology itself or failure in the use and application of technology. So we're going to talk about examples of both. So you may have seen this headline recently from Los Angeles Times when Cerner, an electronic medical record which is used all over the world, had a 5-hour downtime that was quite unexplained. It affected hundreds of hospitals across the world. Nobody knew why this downtime occurred, but people were actually pretty much unprepared for this. And there were a lot of surprises. And there was no information publicly available except that from Twitter feeds. So we tried to create a scenario of what really happened. But anyway, there were a lot of people who suffered through this. This is an example from many years ago, happened in the National Health Service in UK, where because of a computer glitch, some patients got Viagra instead of Zyban. Of course, many patients were not too unhappy about it. But again, this is a problem that could occur in many other places and probably is occurring as well. So let's actually now talk about the use or application of technology. Let's start with a problem that IT can solve. Okay, IT can solve transfer of information from point A to point B. So let's focus on communication. Communication breakdowns happens to be, I'm sure as the patient safety conference next door is discussing, the most common reason for medical errors and adverse events. So let's see, maybe IT can fix communication breakdowns. So what we did in the last few years of our work was evaluate whether IT was really fixing all the communication breakdowns that there were. And so I work in the VA system, so we have obviously an integrated health record. We're able to access patients' data in a longitudinal fashion, across the entire healthcare system. So we do have all the data available. So in the VA system, either the lab or the radiologist codes the abnormal result as in some form of structured data, so the computer can recognize this as abnormal. So what it does is it sends a message to the EMR screen of the provider who ordered the test. So if I order a chest X-ray and the radiologist reads it as abnormal, they would code it as such, and I'll get a flag on my EMR screen that this is abnormal. I'll then go click on the report and then take action whatever is needed. Similarly, if the lab is abnormal, if the thyroid function is elevated or the potassium is high or something, the lab can actually get that automatically flagged into the EMR. This is what the view alert window is. When I open up the EMR, here are the messages that I've received, the flags that I've got. We call them alerts or notifications. And I can then see, as you can see, a lot of alerts come through. In an integrated system, everybody wants to communicate with the doctors, right? So I get a message from the cardiologist, I'll get a message from their lab. So you go into this system, you click on the alert, it takes you to the patient record, and then the computer can track that. So the computer knows when you checked on your alert and you saw it. So we thought that if the doctors are clicking on their alerts, in which case we're looking at communication of abnormal test results, the action would be taken. They would take follow-up action on the problem. So if the chest X-ray was abnormal, had a suspicion for cancer, maybe I'll do a CAT scan next. So what we found was in about 1,000 alerts that we looked at, about 300 of those, the providers had not clicked on the alert. There was no message acknowledgement is what we call it. And so we assumed that, maybe all of them were lost to follow-up for those patients. But when we looked at the medical records and we called the providers to make sure that they had taken follow-up action, we only found that about 46 of those 300 or so, there was no follow-up action. So even when providers ignored their alerts, they were getting the information from some other source. For instance, the radiologist called them or the nurse called them and say, hey, can you go into the patient record to check this abnormal test result out? So then we assume that if, as researchers, we have to ask the question, if somebody is clicking on their alerts, we're assuming they're taking follow-up actions, but how do we know that? So we thought we'll review the records of all the providers who were clicking on their alerts, assuming that they'll be taking follow-up actions on all of them. So now we have two cohorts of patients, one in which providers were not clicking on alerts, and the second where the providers were clicking on their alerts. What we found was we looked at both abnormal imaging and abnormal lab tests. What we found was it didn't really make a difference whether you clicked on the alert or not. And so what we were finding was, even when providers were clicking on their alerts in their EMR, they sometimes were not taking follow-up actions on what they were finding. So for instance, somebody's abnormal X-ray, there was no follow-up action with a CAT scan at 30 days. Why? So we started exploring reasons. One important reason that we found was when one test result was sent to two providers, because let's say I ordered the test, but I want the result to also go to the primary care doctor. The result would go to two people. So you can imagine what happened. Each thought that the other one's going to take follow-up action on the alert, and none of them did. And so we found that there was a higher incidence of loss to follow-up in times when alerts were sent to two people, like a second person as a backup. So we started digging deeper through some of focus groups and other interviews. What we found was providers receive a lot of these alerts. We also found a lot of other, what we call socio-technical reasons of why these test results were not getting followed up. And so these included not just software and technology issues, but also sort of, you saw the user interface, it was not really good. There was too much, signal, there was a poor signal to noise ratio there. A lot of the people who were, going on vacation, they didn't know how to assign a surrogate provider to cover for them when they were leaving. And we found that that providers were not adequately trained to use the EMR system. So, in the morning I heard somebody say training, training, training. It's really important to get the training right, because we had providers saying, I've been in the VA for 8 years and I didn't know how to do this. And so it's very important. Second example is that of computerized provider order entry. Just going to tell you very briefly that what we found was it's supposed to structure the data. If you look at the screen, this is actually a CPOE screenshot of the VA system. You are also allowed to put free text comments. So you can actually put structured data and then put free text comments which are totally contradicting what you put in the structured data. So we looked at these prescriptions. Out of the 532 prescriptions we looked at, which had free text comments, 20% of them actually had errors which could have reached the patient and caused harm. For instance, in the last one, the Coumadin, in the Coumadin example, the patient could have been taking 5 milligrams extra on Saturday and Sunday, rather than taking it just 5 milligrams Saturday, Sunday, and 10 milligrams every other day of the week. I don't know whether you can see that, but that's what the prescriptions intend to say. So the whole point of this, this is a hard area. What we use is a socio-technical model in our work, and we think each and every dimension from the socio-technical model should be addressed in case we want to get this, health IT thing right. And so we actually ended up defining the error, which is in a paper that we wrote last year. You can look at the paper, the slides will be available. So, patient safety in the health IT world, there's three things we have to do. One, you need to address concerns from technology itself. Second, you need to address concerns from failure to use or apply technology. And third, most important, which we didn't really talk about much here, but is to use the technology to monitor and improving safety. And there's the last slide. The take-home point is we really need a socio-technical approach, which includes not just the technology part, but all the other social elements that I was trying to display in that diagram. Thank you.
Thank you. Thank you very much, Hardeep. That shows a lot of insight, and these can come only after somebody has practiced it. And this session is going pretty interesting. Hardeep, thank you very much again.
Thank you so much again. Bye-bye.
Thank you. Hardeep has to catch a flight, and he was kind enough to stay back with us. This session is going pretty nice and interesting. If you recollect what Vijay Raghavan was trying to get to us, he was telling us, keep your HIS focused on the patient experience. And here Hardeep is kind of grounding us once again. Be careful of the technology pitfalls, know what you're doing. Our next speaker, Sandeep Chatterjee. Sandeep is from Oracle India. Sandeep has over 12 years of experience in manufacturing, maintenance planning and control logistics, supply chain, consulting, over 8 years of experience with ERP implementations, Oracle E-Business Suite. Sandeep is going to talk to us about demystifying information asymmetry, the Aurobindo Pharma journey.
Good evening. What we have been seeing for the last 2 days is how IT can help health. Talk about affordability, it means that my entire end-to-end supply chain cost has to come down. And if you look at it, the price of drugs actually form a substantial cost of the supply chain. So if you have to reach anywhere near affordability, the prices of drugs have to come down. And if prices have to come down, the costs have to come down. Now you will ask me, why should a pharma company reduce the prices? I don't have an answer, but if you have been following up the news, Cipla actually reduced the price of cancer drugs by 75%. It actually created a price war in the market. Price war is mostly good for the consumer. So if I have to reduce my prices, I have to be more efficient, or another way is I have to reduce my drug discovery costs, which may not happen immediately because it's a long process. So here we look from a pharma company's viewpoint, how they were able to achieve significant savings in their operations, and it may so happen that they can actually pass out some of the benefits to the consumer. So I have an agenda. I will talk very briefly about Aurobindo Pharma. It needs no introduction. I will slightly touch upon, because I have introduced the term, about information asymmetry. I will talk about the business challenges which they faced. Some of these are applicable in hospitals as well.